are you sleeping? Are you sleeping? I'm Dr. Shelby Harris, Director of Sleep Health at Sleepopolis, and this is Sleep Talkin' with Dr. Shelby, the show that dives deep into all things sleep so you can get the rest that you deserve. Today, we're talking about sleep apnea in children with Dr. Christopher Allen. But first, how's your commute? If it's brutal, it's likely impacting your sleep. According to a study by the National Sleep Foundation, as commute times increase, so does the likelihood of insomnia. By surveying over 50,000 individuals, the study found that those commuting more than 2 hours a day and working over 41 hours a week were at higher risk for insomnia. But it isn't the commute itself, interestingly, as much as the additional stressors that end up impacting sleep. So lost time, energy, and resources, for example, combined with periods of low physical activity, they can increase cortisol levels, contributing to poor sleep. Additionally, some researchers point to less family time and relaxing time impacting emotional health, which is also very much linked to sleep. So if your commute's on the longer side, compensate by getting out in the daylight more often, try to really prioritize that bedtime, or if you take public transportation, find opportunities to relax or nap or move around if possible. What's your take on this, Dr. Chris? Do you have much of a commute?
It's very fortunate that, like, when I commute, I used to commute I live in a small town, so
Yeah.
my commute used to be like 15 minutes, and now it's down to 7. And so, I don't commute as much as I do before, which is great. It's a good and a bad
Yeah.
thing. Good thing is that, yeah, once you're in the car, it's not long to get there, but unfortunately, you take advantage of that. It's like, oh, I got 7 minutes. And
I feel
then
you.
that
Yeah.
7 turns to 3 minutes.
Yep.
But when I used to train for my residency, it was in Chicago. Now, that was a commute.
Oh,
And so,
gosh.
yes, I used to commute, and I agree. You have to have great rest and great quality sleep while you're commuting because it definitely can affect your attention.
Yeah.
And especially in Chicago, it used to be an hour and a half because
Yep.
my wife, we only had one car. So I
Yep.
had to commute 45 minutes south, and then she was also in residency, so I had to pick her up. Then we had to pick up our daughter and then go home.
Oh, my God.
So,
Yeah, I feel
I,
you. Yeah,
so
I
I
work in the New
appreciate the
York
small
City
commute.
area. Yeah, I
Yeah.
work in the New York City area. So many of my patients, they're commuting sometimes an hour, sometimes 2.5 hours. Some will take a drive to the car to the Metro North, then transfer to the subway all the way downtown. It's bonkers how long some of these commutes are. Yeah, I commute to my office now. That's like 10 minutes away. And most of the time I just walk upstairs to my home office, and that's where I see a lot of my patients.
Hey,
So I really can't complain.
look, I appreciate the small things,
Yeah.
and I tell, like, I earned those stripes. I earned those 7 minutes to drive, because even when
Mm-hmm.
I started working, it was even like 30 minutes when
Yeah.
I started working for a company before I went out on my own. Then I cut it down to 15, and now 7. And I'm like, okay, that is good. I don't need to like. I was like, I don't think I can get any lower than that.
Right. I was in Manhattan and was working a lot. And as a student, same thing. And training at Montefiore, the commutes were long, but now I don't have much of a commute. What does sleep apnea look like in a baby? How does it affect children as they grow? And how can we care for sleep apnea sufferers at every age to minimize risks and optimize sleep quality for our kids? To learn more about pediatric sleep apnea, we've invited Dr. Christopher Allen, a board-certified sleep doctor. Dr. Chris has been a sleep expert for the past decade. He helps patients find quality sleep virtually and in person through his practice in Saginaw, Michigan. As CEO of Quality Sleep and Neurology, PC, Dr. Chris is transforming sleep for patients of all ages. Dr. Chris, I am really thrilled to have you here and joining us for a deep dive into pediatric sleep apnea. Welcome to Sleep Talking with Dr. Shelby.
Hey, I'm Dr. Shelby. I'm very happy to be here. And, long time listener, first time on here. So I'm just glad that you're here. I'm here. And yeah, so I'm really excited. And I always tell people, I'm very passionate about
Yeah.
sleep. And so just to have a chance to talk about it, I'm just really excited about that.
Yeah, I think I haven't known you for many years, but in the few years that I've known you, you're one of those people that you can just feel how passionate you are about what you do. You don't get that sense from everyone. And I absolutely love that about you. So thank you. And I really think that you're being here today to talk about pediatric sleep apnea is going to be so valuable for so many people because we often talk about adult apnea. We don't talk about it in peds. We just don't that much. So I think you
Yeah.
have a really valuable level of expertise that I think a lot of people are going to learn from.
Yeah, and I appreciate that. And you'd be surprised, a lot of people don't think about children when it does
Mm-hmm.
come to sleep apnea. There are a lot of parents that, that have been fortunate to have their children diagnosed and they know
Yeah.
about it. But, sometimes even with their friends and their school friends, I would see patients because, like, yeah, you see, like, my best friend's like daughter and she was talking to us and found the same symptoms, and so it is really important.
Yeah. So along those lines, what would be some of the common signs and symptoms that someone would want to look out for in children that might indicate sleep apnea or just further follow up with your doctor or a specialist?
Well, it's always about how they're sleeping. And
Okay.
I always tell patients that sleep apnea, as you alluded to, it's different from it is in adults than it is in kids.
Yeah.
Unfortunately, with obesity that has plagued adults, it does children. So there can be some similarities, but
Okay.
usually in children, it's signs of sleepiness, and that comes with them being hyperactive, very moody, and a lot of times it can mimic ADHD. And so I see a lot of patients, and I'm also a pediatric neurologist in my clinic, and they're coming in because concerns for ADHD. But then when I talk to them, those are some of the questions that I ask, how are they sleeping?
Yeah.
Snoring still plays a role as well. So if you notice that your child is snoring, when they wake up and they still feel like they're tired, or you can tell when you have a fussy child and they're not getting like good sleep, and if there's symptoms that are similar to ADHD. Now, there
Hmm.
are patients with ADHD and obstructive sleep
Yeah.
apnea, but that's a rule as well. And then also, it's as simple as telling them to open their mouth. Because usually, one of the big reasons for obstructive sleep apnea in kids is airway obstruction because of
Hmm.
tonsillar hypertrophy. So, the tonsil, you open up and you see, like, if you see two tonsils and they're very prominent, then that's when you want to talk to your provider to see to get an evaluation from a sleep professional so they can further delve into that.
So let me just back up for 1 second. You said that hyperactivity is a sign
Hmm.
potentially. So,
Potentially, and an
right?
intention.
So I
Hmm.
think that's a huge piece that people don't often think about, right? Like they, I think, assume that a sleepy child looks sleepy. They don't all the time. So is it more common that you would see someone who's hyperactive that would be sleep deprived or have poor quality sleep?
Yeah, so the younger the child is, it's more so like inattention, hyperactivity, also
Interesting.
a history of snoring as well. Now, you can see some signs of sleepiness, and that can be there, but that's not one of the higher markers for it.
Hmm.
And so a lot of patients will look at themselves because it's a strong family history for obstructive sleep apnea. And it's like,
Yeah.
well, dad snores, he's pausing and breathing, and he's tired. I know my son doesn't have it because they're basing it off adult criteria. But usually within
Exactly.
children, it's there is a difference where they should be evaluated.
Yeah. So what about the you were saying in general that the hypertrophy of the tonsils and the adenoids, all that can be a problem. Why is it that that would cause some of these issues?
And so when you fall asleep, all the muscles in your body are relaxing, even the
Yeah.
muscles in the back of your throat. So, like when if this is your mouth and back of your throat, when your muscles relax, your airway is collapsing. And so, and you're already when you're a child, your airway is already small, and so there might be something compromising it. So you have tonsils that usually are smaller when you get older. If they're in the way, and especially adenoids, which are further in the back of your throat, which you can't see, you literally need a tube to go down to actually see
Yeah.
them. But you can see the larger tonsils that can obstruct, especially when you're falling asleep. And
Okay.
then also, there's other signs that you can tell when your child is sleeping. So, for example, if they sleep with their mouth open, they're tilting their head up, and their neck is arched. And if they're sleeping
Okay.
like that, you can tell as well.
Interesting. So having your mouth open when you're sleeping. What about people who are or kids who are just walking around with their mouth open, who are more mouth breathers? Because I've seen that that's a concern for a lot of people.
That can play a role too, and they have something that's called like adenoidal facies, where it looks like, I call it like a blank, surprised look, and like
Hmm.
sometimes their mouth are open, their eyes are a little drooping more, and you also see like sometimes there can be mild swelling like around the eyelids, where you
Hmm.
can tell like in the face, like okay, just looking at them, you want them to open up their mouth. It's like, yeah, their tonsils are large. This could be affecting their sleep. Now, one of the things I want to be clear about, just because you might have large tonsils doesn't necessarily mean that you have a sleep disorder like obstructive sleep apnea.
Yeah.
And so I don't want someone going at home, it's like, all right, son, come here, open your mouth. Wait, your tonsils are large. It
Yeah.
goes in hand with asking the question, like, how are they sleeping?
Yeah.
Are they snoring? Do they feel fussy during the daytime or even a little bit tired or concerned for inattention or hyperactivity?
Yeah, that was something whenever I do trainings with or talks with anyone, because I give a lot of talks to psychologists and psychiatrists a lot of the time.
Hmm.
One of the questions that I just always I hope that they will ask after finishing my talk is just asking a kid or the parents, do you snore? Like that
Yeah.
simple question. If you have
Yes.
anyone who has some hyperactivity or any of that behavioral issues that they're concerned about, just ask, do you snore? And that can open the gates to so many different ideas of what might be going on.
Exactly. There's so many patients. And again, I always tell people that me being a neurologist makes me a better sleep doctor and
Hmm.
vice versa, because I will see patients that come in for headaches.
Yeah.
And sometimes one of the symptoms of obstructive sleep apnea, you can have morning headaches. And so I'm just seeing them and it's like, oh yeah, he just has headaches and they're happening in the morning. I'm like, oh, just in the morning? Yeah, this is where it's the worst. And through the daytime, it is better. And we tried Tylenol and it's not working. And I'm like, okay, and I'm examining them. And then, my neural exam, they open their mouth and then bam,
There you
large
go.
tonsils. And then I ask that simple question, do they snore?
Yeah.
All the time. I'm like, oh, are they hard to wake up? Yeah, sometimes. And then I look in their problem list. You might see like hyperactivity. I'm like, I think we need to get a sleep study to further evaluate this.
Yeah, that makes a lot of sense. Um, oh, that's actually an interesting point that you brought up. So, getting a sleep study. So, what would be involved in a pediatric sleep study? So, we're talking maybe babies or children. Like, how do you even do that?
So you go in for a sleep study, which is a polysomnogram, and the thing is that you can have it from birth all the way to 18, and there are many ways to do a sleep study. I'm talking about the gold standard way of a polysomnogram, where you go into the sleep lab, and in the
Hmm.
sleep lab, for people that are not aware of what it is, you go in. They will put monitors on your chest, on your abdomen, because if you're pausing and breathing, there could be like a decrease in breathing, which is seeing that. And then also a flow sensor and a thermistor just to see if the breath rate is decreasing or stopping at all. Then also you'll have an oximeter to look at on your finger, because if you're decreasing in breathing, what do you think happens to oxygen? It goes
Yeah.
down. And so it looks at that, and then they have a limited EEG on your head so you can see what sleep stages you're going through. And then you have limb leads where they're on your legs to see if you're doing any type of movements, because a sleep study not only will tell if you do or don't have obstructive sleep apnea, it tells everything what's going on.
Yep.
If you're moving in your sleep, why are you tired? It could be, movements or just even your legs jerking or anything. And then there's a camera to, help you see like, okay, well, the legs are moving, so what is actually happening? So that what takes place in a sleep study. And honestly, you can have it as young as newborns that come in. There's just
Yeah.
different criteria that you look at, because your sleep stages are different in the newborn phase compared to when you're like 6 months and
Yep.
moving forward. And so when you're older, then it's pretty much similar to how you look at it for an adult. there are criteria that are different from saying if you have obstructive sleep apnea of how you grade it once you're reading the sleep study.
So I can imagine that you get this a lot. There are probably parents who are saying, there is no way that my 5-year-old would ever sleep with all that stuff attached to them. How can you kind of help someone with that thought process? Because they might not even want to go through
Well,
evaluation at that point.
well, I always tell them, heard that before, fixed that
I'm sure
before.
you hear that all the time.
And it's, we're very fortunate where we have sleep techs that are highly trained to deal with children. And I would say
Hmm.
go to a place where they are, child friendly. Because
Okay.
going there is like, they use special words to the kids like, hey, we're going to wear a special hat and it's going to be on here and you just put it on. My son even had a sleep study. At the time he was 4 years old, and
Wow.
so he puts it on, and it's a special hat, and then you just lay down, and then remember, Mr. Sandman, he's going to win. We just need, we have about over 8 hours of opportunity to get that data. So once they go to sleep, they may not have to hook it up. They let them go to sleep, and then they're
Hmm.
very trained to do that.
Good.
And unfortunately, there are some times where they might have to go back, but that's sometimes few far in between. And there are some children that have special needs where they
Yeah.
might be concerned that that could happen, and they do the sleep study very well.
Yeah.
And so
And the parent can be in the room with them usually?
for children, they have to be in
Yeah.
the rooms. The
Good.
parent has to be there or someone they trust that's over 18.
Good. And they don't do home sleep studies for kids.
So for insurance purposes, they do not do home sleep study for kids. Now there are some studies that are going for older children because the
Hmm.
American Academy of Sleep Medicine, they will allow a sleep study to happen for to using adult criteria starting at 13 years old.
Oh, I didn't know that.
So how I perform, I'm like, look, until you're an adult, I'm going to treat it like a child because development wise, you're not an adult, and there's
Yeah.
still some criterias that are different from adult and kids.
And
And
you're
unfortunately,
getting an in lab, which is even better.
yes, and the criteria for children, not only do you look at the decrease of oxygen, you look at CO2 monitoring. And
Okay.
so the oxygen, like they might be breathing and it might be a little decreased, but then you also look at the CO2 component, and
Hmm.
that component you can't do at home.
Okay.
But with advancement in technologies, there are some devices that some people are using in children. But as far as like, insurance reimbursement and sound data, because there's still some more data that needs to come out there in children. And unfortunately, like in life, the the numbers with kids are not as high as the number in adults. And
Yeah.
so the best gold standard way, and I still stick to that, is bringing the kids in lab for a test.
Makes sense. So, can you explain the potential long-term effects, or even shorter term, other than behavioral, like we were talking about with the hyperactivity, but
Yeah.
some of the effects of untreated sleep apnea in kids, physically, cognitively?
Yeah, and so as you were saying earlier, I mean, it's important for kids to get sleep because it helps with performance outcomes.
Yeah.
And so outside of we've mentioned hyperactivity and attention, you know, excuse me, it also leads into them being like within their performance. They've seen studies of how people are performing in comparison to people that are not knowing that they have obstructive sleep apnea compared to when they actually get treated and their
Mm.
symptoms have resolved, and saw how their performance have increased. So you have that as well as far as like memory and cognition, that is a decline. Also with IQ, that plays a role as well. And then especially when you get older, for the long-term effects, there's concern for growth delays, cardiovascular disease, more so in adults, but that can happen in children as well. And then also difficulty in learning, as we were
Mm.
talking about, and then memory and retention. Because when you're sleeping, the best way to consolidate memories is when you're sleeping at night. And if there's anything that is chopping up that process, like a
Yeah.
sleep disorder, that plays a role as well too.
So, if we've now diagnosed apnea, or we're thinking to at least get it diagnosed, what would be some of the treatment options that are available for kids specifically?
Yeah, and the thing is that as I started at the beginning, it's different than it is in adult than kids,
Yeah.
because there might be a parent that has sleep apnea. It's like there is no way that my child is going to wear a CPAP.
Yeah.
And CPAP therapy is a treatment for obstructive sleep apnea and pretty much the gold standard for adults. But in kids, it's still an option, but it's not the number one option. And
Hmm.
as we were mentioning earlier, you're talking about like tonsillar hypertrophy, so large tonsils, large adenoids. We will refer them to our ear, nose, and throat specialist, and they will see if they're a candidate for removal of the tonsillar tissue. So, adenotonsillectomy, that's the gold
Hmm.
standard for it. Now, it depends on severity as well. So, you have mild, moderate, severe. And if it's mild, it's the question of how it's affecting the child. If it is
Yeah.
affecting the child, we could wait and see. And there have been like multiple studies about figuring out what to do in that comparison. And that's the conversation we have with the parents.
Yeah.
I attempt to look at the side effects and how it's affecting the patient. If they have mild obstructive sleep apnea, I still might go to that gold standard of adenotonsillectomy, taking out the tonsils.
Yeah.
Another way, there's also medication that you could use to help shrink that tonsillar tissue. So you have nasal steroids like fluticasone or Flonase that will help, and over time it helps open up that airway because that tonsillar tissue is decreasing.
Hmm.
That's another way. There's also oral medications you can take as well. There and so those are the mainstay therapies for it. There's myofascial therapies for it too, but usually with the patients, especially, it's not like a cut and paste method. I
Yeah.
look at each patient singularly, and if they have tonsillar hypertrophy, then I'm going to the source.
Yeah.
And the biggest thing that I want people listening to remember is that it always depends on the severity. So if they have obstructive sleep apnea and they get treated, the question is, did it work? The way to answer that question, I don't know. You usually have to get another test to see,
Yeah.
depending on the severity. So if they had mild and I get a treatment and I know that like their symptoms and they seem better symptomatically, then I'm
Yeah.
like, okay, let's just keep watching. But if they had severe obstructive sleep apnea and we got treated and they seem that it's better, I still would want to check.
Yeah. Know what you're dealing with a bit. Yeah. I actually worked on the chat studies, which were
Yeah.
the many
Oh,
years
good
ago.
old chat. Yes.
I was supervising the neuropsych evaluations at our site in Montefiore, and it was just such it's a groundbreaking study to
Oh, yeah.
people who are, many papers have come out of it, but it was looking at in kids, because there really wasn't anything around at that time.
Hmm.
Do you remove the tonsils and adenoids, or
Oh,
do we
yeah.
watch and wait for them to grow, and hopefully the adenoids and tonsils aren't going to crowd the airway as much? And lo and behold, like you were saying, especially with like moderate severe apnea, we saw huge gains when we had them taken out and didn't just wait, because you could see how much they were getting with their behavior, how much better their
Oh,
sleep was,
definitely.
their learning at school. Like we used parent reports, teacher reports, we did sleep evaluations. I mean, there was so much stuff. It's really a great. If anybody's interested, like look up those
Oh,
studies,
yeah.
because it was
It is.
multi-site. It was great.
Yes, it was a fundamental study like in our
Yeah,
field. And one of the things is, and as you mentioned earlier, is that severity. So when
yeah,
it's moderate to severe, we're talking about what can we do to institute treatment.
yeah.
And CPAP therapy is still a treatment for pediatrics and in children. I mean, for children. So it's still an option, but it's not our go-to initially. And
Yeah.
there's some times where I will treat it as a number one option because the parents might be hesitant and might not want their child to have an operation. And so I'm
Hmm.
like, that's okay because there's many ways to treat. And
Yeah.
especially if they have like moderate to severe, I'm like, we can try CPAP therapy depending on the age. You just have to remember, like with mask, there's specific mask choices for children are less than adults, and you never want to
Mm.
use a full face mask, especially
Oh
if they're
yeah.
growing, because their facial features are still developing. And so if you have a mask on every night, that can play a role. And it's funny, I would be the stickler in the sleep lab telling the sleep techs, like, look, any child comes here, what is the one thing that they do not get? And they all repeat, no full face mask. I'm like, exactly.
Good. Very good. So if you suspect there might be some sleep apnea and you go to your pediatrician and they're like, yeah, we should get an evaluation for it. I know there's some confusion. I get asked this by patients once in a while, or even friends and parents. They're wondering, like, do we go the ENT route? Do we go to a pediatric sleep center that might have neurologists such as yourself there? Like, where do you begin?
So it begins with that question.
Yeah.
And and there's many, and that's the hard part about it, because there's many ways to get to the diagnosis. There's usually three options. One, the provider, so if it's a pediatrician
Hmm.
or a family medicine provider, that will hear about it, they'll just order the sleep study and go to the sleep center and get an answer, and then
Yeah.
figure out where they need to go from there.
Okay.
I always say that it will sound a little biased, but I will say, like, they should go to a sleep professional, because
Okay.
not only do we look for obstructive sleep apnea, we go through all types of sleep. I always joke with my patients, I'm not a sleep apnea doctor, I'm a sleep doctor. So we're going to ask all those questions from there. And then, yes, through going to the ENT doctor, so at otolaryngology, going there, they're going to look at it and say, well, yes, you could be a candidate for an adenoid tonsillectomy, and it looks like you have an concern for obstructive sleep apnea. So we're going to get a sleep study. And
Yeah.
then when they look at the study, then they're going to intervene. But I like, having someone quarterback that system. So going to a sleep professional, if you have that option in your area, is very fundamental, because they're going to coordinate everything. They're going to let their provider know, yes, your patient does have obstructive sleep apnea. We're setting up therapies and talking with the parents. It
Yeah.
looks like they are a candidate for surgery. So we're going to refer to our colleagues to make sure that it can happen with ENT.
Okay, that makes a lot of sense. Is there any sort of a database or a search where someone could look to see if there is a pediatric sleep medicine doc?
Oh yes, I mean the thing is that if you go to the American Academy of Pediatrics, I think they have a database. But the good old American Academy of Sleep Medicine, you look that up, you'll see some great names on there, and you might even see yours truly on there if you're in Michigan. Shameless
Mm-hmm.
plug for that, and you can look through there. And so there's a way to look at that, and then also ask your their primary providers for your kids,
Mm-hmm.
because they're going to know where they usually send out. But if they're having problems with that, then yes, you can definitely go online to look at that.
Okay. And then is there anything that parents can do just around the sleep environment or the environment in general during the day that might help with if they're undergoing treatment for apnea or they're being evaluated? Is there anything with their sleep that you would recommend that they do?
Well, always at the beginning, sleep hygiene is everything.
Okay.
And when I say it's everything, it's the most simplest thing you can do all around, even if
Hmm.
there's not a problem.
Okay.
Because the thing is that a lot of people will say, like, well, I did the sleep hygiene, there's still a problem. Then that's when you
Yeah.
get evaluated. But at the beginning, making sure that you're going to bed at a consistent time, making sure that you know that the bed, especially in children, is only for sleeping or if they're sick, and making sure that they have a good environment where there's no electronics going on, not the TV, not the tablet, getting good times beforehand. And if they do have a sleep disorder, and that's the hard part about it, because they'll see me as, in my clinic, and I'm giving
Hmm.
them, I'm like, they know what there's going on. I'm like, okay, well, when's the sleep study? Oh, it's going to happen in the next 2 weeks. It's like 2 weeks. Well, what am I going to do until then?
Hmm.
So at that time, if you know that they have, I always reassure the family, even though this is happening, their body is aware. So
Yeah.
yes, are they having crummy times right now? Yes, but this is not going to affect them over within these next 2 weeks. Now, if we're doing this over like 2 months, 2 years, yes, you'll see more of an effect. So it's reassurance first, and then just letting them know, sleep on your side, because gravity is everything. So if they're sleeping on their back, you can prop them up. That's
Yeah.
something to hold it. That's not the fix. It's something to hold during that time as well. And then also just establishing, letting them sleep in their room. And I say that with a caveat. I know there's cultural differences, where it's like, look, this is what we do in our family.
Yeah.
We lay in the bed together, and that's fine. I never want to mess with anything that's cultural, but if we do have some issues, those are some of the things that I will tell patients.
Okay. That makes a lot of sense. Dr. Chris, we always like to end with a segment called Something to Sleep On. So it's one last point for anyone looking to change their sleep habits. So considering everything that we've talked about today, Do you have any one final point for our audience? Maybe something to sleep on?
Yeah. Well, it's a segue into what we were talking about earlier, because one, something to sleep on, it's sleep. Sleep is important. What happens at night affects your daytime. So it just does start with that simple question: do you snore?
Yeah.
Because an answer to that question can lead to other things that can actually lead you to getting quality sleep.
Yeah, that's so important. And I think we're always focusing on exercise and diet and all that. But really, the basis of all that is a good night's sleep routinely.
Most definitely. And it's funny because, within the new year, you have your resolutions, and even with exercise, recovery
Hmm.
is everything.
Yep.
Recovery is sleep. Even with, like, being more organized,
Yep.
getting good sleep will help you with better outcomes.
Yep. It's so important. Well, thank you so much for being here, Dr. Chris. I could talk about this all day with you. I mean,
Oh, Dr.
it's
Shelby,
it's a
I could
topic
do the
that people
same
don't talk.
thing.
Thank you. And I really do think that this is something that for anybody with kids or grandkids, I think that this is something that they're going to start thinking a little bit more about, because there's so many of those like cute snoring videos of kids
Oh,
out there that maybe they'll look at it a little bit different from now on.
oh, definitely.
So thank you for being here. I really appreciate it.
Oh, thank you, Dr. Shelby, for having me.
Thanks for listening to Sleep Talking with Dr. Shelby, a Sleepopolis original podcast produced by Ready Freddy Media. Remember, if you're tired of hitting snooze, hit subscribe or follow right now in YouTube, Apple Podcasts, Spotify, or wherever you're listening. And for even more sleep tips, visit sleepopolis.com and my Instagram page at SleepDocShelby. Until next time, sleep well.